As we heard in the video the other night, or day, pardon me, 90% of the people with diabetes have type 2. So that is the most popular, if you want to say popular, type of diabetes. It is diagnosed most often in middle-aged and older adults and is higher in men than women. Diabetes is a chronic metabolic disease that requires lifelong behavioral and lifestyle changes. In the United States, diabetes is the leading cause of new cases of blindness, end-stage renal disease requiring dialysis or teeth transplantation, and foot and leg amputations. Many people with diabetes are undiagnosed, and among those who are diagnosed, many have continuous high blood glucose levels. Diabetes is a major public health problem, and its complications, especially hypertension, hyperlipidemia, which is high blood lipid levels, cause serious health problems. The complications of diabetes can be greatly reduced with glycemic, which means blood glucose, control, along with management of the hypertension and hyperlipidemia. Diabetes mellitus is, of course, a disorder of hyperglycemia, which is high blood sugar, and it results from defects in insulin secretion, insulin action, or both. It leads to abnormalities in carbohydrate metabolism, fat metabolism, and protein metabolism. There is a discrepancy, there is a discrepancy between the amount of insulin required by the body and the amount of insulin available. The role of insulin is to transport glucose and amino acids across the membranes of many body cells, particularly muscle and fat cells. When glucose goes into the cells, it allows the cells to make energy. The four major types of diabetes are type 1 diabetes mellitus, type 2 diabetes mellitus, gestational diabetes, and other specific types. The cause of diabetes is not known, but genetic and autoimmune, viral, environmental, and socioeconomic factors have been implicated in the development of the disease. So genetic, autoimmune, viral, environmental, and socioeconomic factors have been implicated.
Can you go over that one more time?
Sure.
Sorry, I'm trying to.
It's thought to be an autoimmune disease. Genetic, it is not known, but genetic and autoimmune, viral, environmental, and socioeconomic factors have been implicated. So there's a genetic predisposition, and then the autoimmune, and then they've implicated viruses may cause this, environmental and socioeconomic. The role of hormones. The endocrine pancreas produces hormones. Those are the alpha cells of the islet cells, and they produce glucagon. The beta cells of the pancreas produce insulin, and the delta cells produce somatostatin. The endocrine portion of the pancreas has about 1 million small glands called islets of Langerhans. The two types of islet cells important to glucose control are the alpha cells. They secrete the glucagon, which is a counter-regulatory hormone that prevents hypoglycemia by triggering the release of glucose from cell storage sites, and we'll talk more about that. Hypo.
Can you say that again?
I can. The glucagon is a counter-regulatory hormone, and it prevents hypoglycemia, low blood sugar, by triggering the release of glucose from cell storage sites, and I'll get on that again. Beta cells produce insulin and amylin, which is a peptide made of 37 amino acids that is secreted at the same time as insulin in response to a meal. This inhibits appetite, amylin inhibits appetite, slows gastric emptying, decreases secretion of glucagon, and inhibits the activity of osteoclasts, the cells that reabsorb bone. Don't worry too much about the amylin cells, though. Mostly we're talking about insulin and glucagon. So insulin prevents hypoglycemia by allowing body cells to take up and use and store carbohydrates, fats, and protein. So insulin prevents hyperglycemia because it allows the body cells to take up the glucose and use and store carbohydrates, fats. Delta cells produce the somatostatin, and again, it's not a really important role in diabetes, but they are believed to be a neurotransmitter that inhibits the production of both glucagon and insulin. But we won't talk too much about this. Okay, so blood glucose homeostasis. The body requires a constant supply of glucose. Not all tissues require insulin to obtain glucose. Normal blood glucose in healthy clients is regulated by insulin and glucagon. Those are the most important hormones. So if you think of insulin, it's like a key, which was discussed in the video, that opens the locked membranes to glucose, allowing glucose in the blood to move into the cells to generate energy. Okay, so it's like a key, and it unlocks the membranes to the glucose, allowing the glucose in the blood to move into the cells to generate energy. The brain, liver, intestines, and renal tubules do not require insulin to transfer glucose into the cells. So the brain, liver, intestines, and renal tubules do not require insulin to transfer glucose into their cells. The skeletal, muscle, cardiac muscle, and adipose tissue do require insulin for glucose movement into the cells. So the skeletal muscle, cardiac muscle, and adipose tissue require insulin for glucose what happens to regulate the blood sugar is if there is high blood sugar, the pancreas is stimulated to release insulin, and the insulin goes to the cells to take up glucose from the blood, and also goes to the liver to produce glucogen, which is the storage of glucose in the liver. And that causes the blood glucose to fall. When there's low blood glucose, the pancreas is stimulated to release glucagon, and it stimulates the liver to break down glycogen. So the glucagon from the pancreas goes to the liver and breaks down the glycogen and releases glucose into the bloodstream. Type 1 diabetes mellitus is insulin-dependent diabetes. And they feel like type 1 diabetes is most likely due to an autoimmune response in patients with a genetic susceptibility. The pathophysiology and etiology, the result of pancreatic cell destruction, is what happens, which decreases the total circulating insulin. And again, it's due to, they feel like an autoimmune response or idiopathic. So what happens are the antibodies attack the beta cells of the pancreas and cause insulinitis, which is insulinitis. And this is the inflammation and destruction of the beta cells that occurs over a long preclinical period. Hyperglycemia occurs when 80 to 90% of the beta cell function is lost. Hyperglycemia occurs when 80 to 90% of the beta cell function is lost. So this is going on for quite a while before the patient actually exhibits hyperglycemia. Right. Hyperglycemia occurs when 80 to 90% of the beta cell function is lost. This most often occurs in childhood, and again, if there's a genetic predisposition, and there are environmental factors that can cause this also. It can be triggered by a viral infection. They felt like, which some of them are mumps, rubella, Coxsackie virus, or due to a chemical toxin. They found some correlation with smoked or cured meats. The risk factor is 1 in 400 to 1 in 1,000 in the general population, and 1 in 20 to 1 in 50 if the person is a child of a diabetic. So there's a lot of genetic predisposition with diabetes. Coxsackie virus. COX SAC, S-A-C-K-I-E virus. Coxsackie virus.
Or rubella.
So the clinical manifestations, the signs and symptoms of diabetes mellitus type 1 are, of course, hyperglycemia, which is high blood sugar, breakdown of body fats and proteins, and development of ketosis. So what happens is lack of insulin causes hyperglycemia. And when there's not insulin, as we've already discussed, glucose cannot enter the cell without it. So it's floating around in the bloodstream. So when insulin is not available, the body breaks down fat and protein, and this is kind of a counter-regulatory response to the high blood sugar in an attempt to provide energy and also increase the levels of counter-regulatory hormones in an attempt to make glucose from other sources. The blood sugar is very high, so there's a lot of sugar in the bloodstream, but it's not getting into the cell, so the body thinks it needs more blood sugar, or more glucose. Does that make sense? Because the insulin's not getting into the cell, so the body says, I don't have any energy, I need glucose. So the body ends up breaking down fats and proteins in an attempt to increase the blood sugar, but actually it makes it worse. Does that make sense? The breakdown of fats releases free fatty acids. So the fatty acids convert to ketone bodies, which are small acids, and this is to provide a backup energy source. So the breakdown of fats leads to free fatty acids, and the fatty acids end up converting to ketone bodies, or small acids, to provide a backup energy source. So ketosis is the accumulation of ketone bodies which are produced during the oxidation of fatty acids. Hyperglycemia also causes serum hyperosmolarity. And hyperglycemia causes serum hyperosmolarity, which means it thickens blood. So with the high blood sugar, there is water that is drawn from the intracellular spaces into the general circulation to combat this. The increased blood volume increases renal blood flow, and the hyperglycemia acts as an osmotic diuretic. So because blood is thick, it draws water into the intracellular spaces in the general circulation, and this increased blood volume increases the renal blood flow, of course, and the hyperglycemia acts as an osmotic diuretic. So that leads to the increase in urination. So here we have the classic manifestations. Polyuria, which is frequent and excessive urination, and as I said, results from the osmotic diuresis caused by the excess glucose in the urine. This diuresis also leads to electrolyte imbalances of sodium, chloride, and potassium also being excreted in the urine. And the water loss is very severe and leads to dehydration, which causes the next symptom of increased thirst, or polydipsia, which is excessive thirst. Because the glucose does not enter the cells, energy production decreases, and this stimulates hunger. So then our third classic symptom is polyphagia, which is excessive hunger. And it's not that the glucose isn't there, it's just that the body doesn't have access to the glucose for energy. So despite eating vast amounts of food, the person remains in starvation until insulin is available to move the glucose into the cells. So you'll also see weight loss, malaise, and fatigue. Type 1 diabetes mellitus requires exogenous insulin, which is outside the body. Insulin inside the body is endogenous. Exogenous is what we have to give the person. Blurred vision often occurs resulting from the osmotic effects that cause the lenses of the eyes to swell. So they may present with vision problems. But the polyuria, polydipsia, and polyphagia are called the three sisters because they are really your classic symptoms of diabetes. This is a little cartoon that shows you the signs and symptoms. Polyuria, hunger, also weight loss, fatigue, increase of infections because of the high glucose, rapid onset. It doesn't really surface until, as we said, 80 to 90% of the islet cells are destroyed, and they will be insulin dependent. There is a familial tendency, and the peak incident is from 10 to 15 years. So it used to be called juvenile diabetes, or it still is called juvenile diabetes, because it typically happens at a young age. Any questions about type 1? Type 2 diabetes mellitus is a more adult onset or non-insulin dependent diabetes mellitus, and it results from a combination of insulin resistance. And what is insulin resistance? The cells do not accept the glucose, so that key does not unlock those cells to accept the glucose, even though it's available, even though the insulin is available. It just, for some reason, will not accept the glucose. And also can be due to a decreased secretion of insulin by the beta cells. The pathophysiology and etiology, the function of insulin is impaired by resistance, and the demand for insulin exceeds supply. This is thought to be caused by hereditary insulin resistance, which is the reduced ability of the cells to respond to the insulin, or an abnormal insulin production, as I said. It is usually the result of obesity and physical inactivity in genetically susceptible people. So there is a genetic predisposition to this. But if weight control and physical activity can avoid this, even in genetically susceptible people. The insulin resistance forces the pancreas to work harder and to produce more insulin because, again, the body's saying, okay, we're not getting this glucose, you have to give us more insulin. But when demand exceeds supply, type 2 diabetes results. Whatever the cause, there is sufficient production of insulin to prevent the breakdown of fats and resultant ketosis. So it does not have to go to those counter-regulatory backup situations and break down the fats. So this is called type 2 diabetes. It's characteristically a non-ketotic form of diabetes. So you can go into ketoacidosis with type 1, but type 2 typically you do not. So it's a non-ketotic form of diabetes. This can occur at any age, usually middle age and older, but we're seeing an increase in type 2 diabetes in younger people. Why is that happening?
Obesity is
rising. So we're seeing it in much younger people, children. So the age of onset is decreasing. A major factor is cellular resistance, and increased, of course, by obesity, inactivity. Some medications also cause this. Illness can help or make this develop, and age. Physical activity increases the cellular sensitivity to insulin and improves tolerance to the glucose. So we need to encourage weight loss, and it also encourages weight loss.
It increases cellular what?
Okay. Physical activity and weight loss increase the cellular sensitivity to insulin. So physical activity and losing weight can in themselves keep this under control because it increases the cellular sensitivity to the insulin. So it makes the cells more sensitive to the insulin. So they accept the glucose. And also improves the tolerance to glucose. Risk factors for type 2 diabetes. There is a genetic predisposition in parents or siblings, diabetics in parents or siblings, obesity, as we said, physical inactivity. There is a race, higher tendency, ethnicity, history of gestational diabetes, and we'll talk a little bit more about that. That occurs during pregnancy. It could be that the pregnant woman had never had any problems with diabetes, but then she gets pregnant and she ends up having problems with her glucose tolerance. So, and we'll talk a little bit more about that. Also, polycystic ovarian syndrome, ovary syndrome, could be a risk factor. Hypertension, and metabolic syndrome. If it would develop into gestational diabetes, in that amount of time, I'm not sure about that. It just says hypertension in general, so I guess it would continue after pregnancy, perhaps. Talking about the metabolic syndrome, what is considered the metabolic syndrome is if a person has hypertension, abdominal obesity, hyperlipidemia, and a fasting blood glucose greater than 100 milligrams per deciliter. So that's considered metabolic syndrome, which puts you at risk for type 2 diabetes. Those again are hypertension, abdominal obesity, hyperlipidemia, and a fasting blood glucose greater than 100. Metabolic syndrome is thought to exist in over half of all Americans who are older than 50 years. are similar to type 1. Often, the person is unaware of the disease until he or she seeks health care for some other problem. Since hyperglycemia increases gradually and may exist for a long time before diabetes is diagnosed, half of those with newly diagnosed type 2 diabetes mellitus already have complications, unfortunately. It is similar in symptoms to diabetes type 1, especially the polyuria and the polydyspnea. So they have a lot of urination and a lot of thirst. However, the polyphagia is not often seen, and weight loss is uncommon. So the symptoms for this are typically polyuria, polydyspnea, increased urination, increased thirst, but polyphagia is not often seen, and weight loss is uncommon. Often manifestations are also blurred vision, fatigue, paresthesias or numbness, and skin infections. Sometimes a person will just come in with a yeast infection, and what does yeast like to grow in? Sugar. So a lot of times that will be what they present with. They have this yeast infection that they just can't get rid of, and come to find out that they've got diabetes.
I'm not trying to interrupt you,
No.
but I'm having a hard time keeping up. Are you going to post your notes?
I will post my notes after we cover everything for you guys to study.
Sorry, but I'm sure.
Yeah. I mean, I'm
I'm
sorry.
furiously writing, but.
Okay. I'm sorry. I'm talking too fast. Yeah, I will post the notes before at the end. Okay. All right. So, type 2 diabetes. Sedentary lifestyle contributes to type 2 diabetes. Familiar tendency. Average age is 50 years. History of high blood pressure. Fatigue or decreased energy. Obesity, as we talked about. Recurrent infections. Polyuria and polydyspnea. And fasting blood glucose is greater than 126 milligrams per deciliter. Gestational diabetes is diabetes during pregnancy, and this develops in 4% of the pregnancies in the United States. It's diagnosed typically at 24 to 28 weeks gestation with the oral glucose tolerance test. Patients have an increased risk for C-section, perinatal death, and neonatal complications with this. Also, mothers are at an increased risk to develop type 2 diabetes in 5 to 10 years. So this can be a precursor to type 2 diabetes. Nutritional therapy, insulin therapy, if not effective. So sometimes they can get through the pregnancy just making nutritional changes and increasing their activity. But some of them do have to go on insulin. So gestational diabetes is defined as any degree of glucose intolerance that has its onset or is first diagnosed during pregnancy.
Is their increased risk for C-section the only reason that it's because they have larger sized babies?
Yes.
That's the only reason they have the high risk?
Mm-hmm. Yeah, I would say that's it, yeah. Because they do typically have larger babies. Because of the increased sugar in the bloodstream, that baby's fed. So, yeah, they tend to be large babies. And if moms are not detected as having gestational diabetes and have a large baby, then and they're suspected that they may have had gestational diabetes after all. So women who are markedly obese, have a prior history of gestational diabetes, have glucose in their urine, glucosuria, or a strong family history of diabetes may develop this. Secondary diabetes occurs due to another medical condition or treatment. Conditions that can cause diabetes to develop are Cushing's syndrome, hyperthyroidism, which we're going to talk about, use of parenteral nutrition, and that is nutrition through an IV, like total parenteral nutrition. Some patients end up being on because they're unable to eat for some reason or another. And this is a very sugary, concentrated solution, so it does cause them to have some hyperglycemia that usually can be controlled while they're having the total parenteral nutrition. Medications that can cause corticosteroids. Have any of you run into this with your patients in the hospital? Perhaps come in, have asthma or breathing disorders, and they're on steroids and their blood sugar goes up. So we like to monitor patients that are on corticosteroids closely to make sure that their blood sugar doesn't elevate too high. Phenytoin also, and atypical antipsychotics can also cause an increase in blood sugar and lead to diabetes. Yeah, typically. So the complications of diabetes involve many body systems. Acute complications due to hyperglycemia can lead to diabetic ketoacidosis, which we're going to talk more about, and hyperosmolar, hyperglycemic state, Dawn phenomenon, and Somogyi phenomenon. The Dawn phenomenon is where there's a raise in the blood glucose between 5 a.m. and 6 a.m. And this occurs in both type 1 and type 2 diabetes. So it's a rise in blood sugar between 5 a.m. and 6 a.m. Believed to relate to nocturnal increases in growth hormone, which decrease peripheral uptake of glucose. And this is managed by providing more insulin for the overnight period, giving evening doses of intermittent acting insulin about 10 p.m. So this is treated with giving intermediate acting insulin at 10 p.m. to counteract that rise in blood glucose between 5 and 6. The Somogyi phenomenon is a combination of hypoglycemia during the night with a rebound morning rise in blood glucose to hyperglycemic levels. So it's a combination of hypoglycemia during the night and it rebounds in the morning and to hyperglycemia levels. This is managed by ensuring adequate dietary intake at bedtime and evaluating the insulin dose and exercise programs to prevent conditions that lead to hypoglycemia. So this is a lot of times managed with a HS snack. You see a lot of the diabetics that have an HS snack of crackers and cheese or something like that. And then if this continues, they may have to evaluate the insulin dose and make changes, and also implement an exercise program. Also, this phenomenon can cause insulin resistance for 12 to 48 hours, the smoking. So again, that may have, patient may have difficulty bringing down their blood sugar for 12, 20, 48 hours, 12, 48 hours. Might be increasing insulin resistance.
I need to alter insulin now.
Blood sugar, mnemonic, helps us remember the signs and symptoms. So if the patient is hot and dry, the sugar is high, and cold and clammy, eat some candy. So that helps you remember some of those signs and symptoms of hyper and hypoglycemia. Yes?
What, sticking in salt?
It started to snow.
It's snowing in Salisbury, far.
Yeah, it's been snowing in Winston for like an hour. It's changed. Yeah, y'all are late. Y'all are late. It's snowing in Winston for like an hour.
And this is the serious end product of diabetes that's kind of out of control. It's where there is an absolute deficiency of insulin and an increase in insulin counter-regulatory hormones that are trying to get that blood sugar into those cells. So there's increased glucagon levels. Also occur when energy requirements increase under stressful conditions, like a patient who has diabetes type 1. This is only in diabetics type 1 that this occurs. If they get an infection, if they have surgery, they're at risk for this happening. Or they decrease or omit their insulin, they're at greater risk for this developing also. It involves 4 metabolic problems: the hyperosmolarity, because there's so much sugar in the blood; metabolic acidosis, due to the counter-regulatory hormones doing their thing; extracellular volume depletion, because of the thick blood, is pulling all the secretions into the intracellular vessels. And of course, with the high blood sugar and hyperosmolarity, then electrolyte imbalances happen from the osmotic diuresis. So this figure goes through where you start with a decreased uptake of glucose results in the breakdown of protein to amino acids for use as an energy source. This is called gluconeogenesis. New glucose is formed. The liver the muscles and the fat cells are metabolized to provide sources of energy, and amino acids from the skeletal muscle are converted to glucose in the liver. Glycerol from fat cells is converted to glucose, and fatty acids or keto acids, which cause central nervous system depression and coma. Increased glucose in C causes osmotic diuresis, which leads to dehydration and decreased circulatory volume. And these processes create the symptoms of diabetic ketoacidosis. The symptoms can be reversed with intravenous insulin to lower the blood glucose. Blood pressure is raised to prevent circulatory failure by administering Intravenous fluids, electrolytes are monitored and corrected. So, so the manifestations result from severe dehydration and acidosis. They require immediate medical attention and are most of the time in ICU. They need to get like 6 to 10 liters of fluid to replace the losses in the first 24 hours. And the IV fluids of choice are normal saline and half normal saline. Regular insulin is used, and electrolyte imbalance requires monitoring. So the person will be admitted to the hospital when the blood glucose level is greater than 250, a decreasing pH and ketones in the urine. If the patient is alert, the patient can take PO fluids. So we're using the normal saline for fluid replacement. And when the blood glucose reaches 250 milligrams per deciliter, then they add dextrose to the fluid to prevent rapid decrease in blood glucose. So then the body has glucose to move into the cells with the insulin. Potassium levels may be normal on admission, but they decrease during treatment and so must be monitored and replaced.
What did you say, like the mean sugar would be?
250. Greater than 250. It can be even higher. They can come in with 1,000 to 2,000 levels. And a decrease in pH and ketones in the urine. The other disorder that can happen, hyperglycemia that's not controlled, and this occurs in people with diabetes type 2. The plasma osmolarity is greater than or equal to 320 millimoles per liter. Blood glucose levels are greater than 600, so their glucose level is even higher. This is serious and life-threatening also. So HHS differs from DKA in that the ketone levels are low or absent, and blood glucose levels are much higher. In HHS, there is a residual insulin secretion. So there is a little bit of insulin there, and that keeps the body from developing ketones. HHS is the end result of sustained osmotic diuresis. The plasma osmolarity is normally 280 to 300. Blood glucose is often as high as 1,000 to 2,000. So their blood sugar is a lot higher with this. And hyperglycemia causes increased urine output, which decreases plasma volume, which drops the glomerular filtration rate, which causes glucose and sodium to accumulate in the blood, which increases the serum osmolarity, which leads to severe dehydration. So it's a vicious circle that occurs. Altered level of consciousness can range from confusion to a complete coma related to the serum osmolarity. Mortality is high, even higher than for DKA, because the people are older and have other medical problems. So precipitating factors are infection, which is the most common. Therapeutic agents can cause this, and therapeutic procedures like surgery. Also, acute illness and a chronic illness can lead to this.
Thank you.
So the treatment is to correct fluid and electrolyte imbalances and to lower blood glucose levels with insulin. first priority for fluid replacement is to increase blood volume. And if shock or severe, hypotension, give normal saline. Otherwise, you'll use half normal saline because it more rapidly corrects the water deficit. And you'll be giving a lot of fluid, 1 liter per hour, until urine output and BP are adequate, and then you reduce it to 100 to 200 milliliters per hour. So they're severely dehydrated. Yeah. Insulin is only added after adequate fluids have been replaced and until blood glucose is reduced to 250 milligrams per deciliter. There is no need to continue to administer beyond that point insulin because ketosis is not present. Serum potassium, like I said, may drop rapidly once insulin is started, so replacement should be initiated once urine output is adequate. Hypoglycemia. This is common in type 1 diabetes mellitus, or it's also called an insulin reaction. It can be precipitated by the intake of alcohol, and some drugs can cause hypoglycemia. Also, this can be called insulin shock or insulin reaction. Causes can be also insulin excess from a dose, because they have variable absorption due to increase, or due to variable absorption due to increased insulin sensitivity, from the resolution of an infection. So someone comes in with an infection and their blood sugar is high, but then as the infection improves, they may end up with hypoglycemia. So weight loss can cause this also. Exercise programs, and we'll talk more about what the patient needs to do to prevent hypoglycemia with exercise, which we want them to do. And then also differences in insulin formulas. We want to make sure our patients don't end up getting a different insulin, which I don't know how they could without a prescription, but not to change brands without medical supervision, because that can also cause their blood sugar to drop. Of course, deficit food intake or delayed gastric emptying, that's very common in diabetics of long duration. They get gastroparesis. So the body, the stomach just has this food sitting in there, so the body doesn't have the food to increase the glucose. Exercise, prolonged exercise increases cellular glucose uptake for several hours. So we need to make sure we teach our patients to monitor their blood sugar and to consume a carbohydrate before and during exercise. Alcohol typically increases blood sugar, but if it's abused, it can inhibit liver glucose production and interferes with the counter-regulatory response that impairs glycogen breakdown, because the liver does all that. So alcohol is more likely to cause hypoglycemia when a patient doesn't eat for a long period of time and basic nutrition is poor. So we want to make sure our patients eat something before they have an alcoholic beverage. And also glycogen stores are depleted. So we need to, like I said, teach our patients to ingest alcohol only with or shortly after a meal. So we consider hypoglycemia to be a blood glucose that is less than 70 milligrams per deciliter. With the manifestations, it's a compensatory autonomic nervous system response. There's also hypoglycemic unawareness, where you'll have patients that don't even have the symptoms of hypoglycemia that newer patients have. And it usually occurs with a patient that's had diabetes for a long period of time. So you'll see these patients that are up walking around and have blood sugars of 30, and you wonder what the heck. But it's just that their body no longer responds to that low blood sugar like it used to. Typically, this occurs in patients who've had type 1 diabetes for more than 30 years. Hypoglycemia unawareness. And here's our signs, and this is a good little mnemonic to remember hypoglycemic signs and symptoms. So, tachycardia, so the patient is tired, right? Irritability, restless, excessive hunger, diaphoresis, and depression. So, treatment for hypoglycemia. 15 grams of a rapid-acting sugar is the best treatment. And there's called the 15-15 rule. And I like this. You give your patient 15 grams of carbohydrate and then recheck their blood sugar in 15 minutes. The exception to this rule is if the hypoglycemia is so severe that you may have to give 30 grams of carbohydrate, which we consider it to be severely low if it's less than 50. So some examples of some 15 grams of carbohydrate things that the patient can take are 3 glucose tablets, a half a cup of fruit juice or regular soda, 8 ounces of skim milk, 5 Lifesaver candies, 3 large marshmallows, and 3 teaspoons of sugar or honey. 3 marshmallows, yes. And there's other examples in your book of what's considered a 15 gram of carbohydrate. But these are rapid-acting sugars that help get that blood sugar up pretty quickly. You do not, and I've seen this done in the hospital, you do not want to add sugar to fruit juice. It's too much and can lead to too rapid of an increase in blood sugar, and it can cause persistent hyperglycemia. And also, it slows down the absorption of the sugar. So, don't want anybody to add sugar to juice. So you just give a 4-ounce thing of orange juice. And you can also treat, now this is if the patient's awake. If the patient isn't awake, we may have to go to other measures. What can be given is glucagon, sub-Q-IM, and dextrose 50%. And this is for patients that can't swallow because they're in a coma, decreased level of consciousness. And our target glucose level that we really would like our patients to be at are 70 to 110 milligrams per deciliter. So the patient should be hospitalized if the blood glucose is less than 50. Of course, if they happen to go into a coma or have seizures, altered behaviors, if no adult can attend to them. And this also can be caused by sulfonylurea drugs, which are type 2 diabetes, PO medications, and we'll talk more about those later. Here's a nice little about glucagon. When the sugar's gone, first aid kit for severe hypoglycemia. When the person is unable to remain conscious, glucagon is given sub-Q, IM, or IV for emergency replacement. And that's it. Thanks for the brain candy. But a lot of times, if they're unconscious, the big thing is you want to watch for nausea and vomiting because of the toxic effect, or because it tends to make them nauseated, like rush of sugar, I would think. The toxic effect can also be hypokalemia, so we want to watch that potassium level. This drug is reconstituted from a powder, so don't use unless the solution is clear. And that little doggy says brain candy, cool. The brain uses more glucose than any other body system. And the brain can't store much glucose, so it's really important that we get the blood sugar up as quickly as possible. That accounts for all those CNS symptoms that patients have when their blood sugar drops. Chronic complications that can occur with diabetes, the cardiovascular system, and what can happen is the macro circulation changes that occur, which cause increases in atherosclerosis in large vessels. And then the micro circulation changes are the capillary and small blood vessels, and they thicken and result in decreased tissue perfusion. Coronary artery disease is the most common cause of death in people with diabetes because of the vascular changes. Hypertension, the ADA recommends, American Dietetic Association, recommends that blood pressure be maintained less than 130/80 in diabetics. People with diabetes mellitus are 2 to 4 times more likely to have a stroke. Peripheral vascular disease occurs in both types of diabetics, but the incidence is greater in people with type 2. Gangrene from diabetes is the most common cause of non-traumatic amputations of the lower leg, and dry gangrene is more common. We had a patient we saw that with. Did your patient have diabetes also?
I don't think she did.
Yeah.
I don't think she did. She didn't take any insulin or anything like that.
But yeah,
I think it was just peripheral.
just vascular disease.
Yes.
She was in her 90s, but yeah, she had the dried up toes, her foot,
Black as coal.
totally black.
So if there's one that's dry gangrene, is there one that's not going to make the other one wet? Is that what you got? Did you got dry gangrene?
Also, another complication is diabetic retinopathy. There's 2 stages to the changes in the retina. After 20 years of diabetes, almost all clients with type 1 diabetes and more than 70% of clients with type 2 will have some degree of retinopathy, and in most cases without vision loss, which is good news. The cause and progression of diabetic retinopathy are related to the problems that block retinal blood flow, again, vessels, and cause them to leak, leading to retinal hypoxia. The 2 stages, non-proliferative, causes structural problems in the retinal vessels, and these develop slowly and rarely cause blindness. Then there's the proliferative, where the growth of new retinal blood vessels, which are thin and fragile and bleed easily, lead to vision loss. Then there's also diabetic nephropathy, which is a pathologic change in the kidney. So it really affects all the organs, and because all the organs get blood supply. And this reduces kidney function and leads to kidney failure. Diabetes is the leading cause of end-stage renal disease and kidney failure in the United States. End-stage renal disease can be delayed by maintaining optimal blood glucose control, keeping blood pressure within normal limits, less than 130/80, using drugs that protect the kidney, like angiotensin converting enzyme inhibitors, or ACE inhibitors, and angiotensin receptor blockers. Kidney disease causes a progressive albumin excretion and a declining glomerular filtration rate. And the earliest symptom is microalbuminuria, is the earliest manifestation of nephropathy. So it thickens the basement membrane of the glomeruli and impairs renal function, and hypertension accelerates this progression. Peripheral and autonomic nervous system. Diabetics have neuropathies, which are thickening of the walls of the blood vessels, the nerves, which decrease nutrients to the nerves. Demyelination of the cells that surround and insulate the nerves slows nerve conduction. And formation and accumulation of sorbitol within cells impairs nerve conduction. So, excessive glucose is converted to sorbitol, which collects in the nerves and impairs the motor nerve conduction. And there's different kinds of peripheral neuropathies. Polyneuropathy is diffuse and involves more than one nerve. It's distal, paresthesia or pain, cold feet. These are the most common, and they involve widespread nerve function loss. They are slow onset and affect both sides of the body, so both feet will be numb or have pain. They involve motor and sensory nerves. And like I said, they progress, or they slow onset, but they also progress slowly. These are permanent and include autonomic nerve function. The mononeuropathy, or focal, only affect one single nerve. Manifestations may include palsy of a third cranial nerve, thoracolumbar radiculopathy, diabetic femoral neuropathy, and entrapment or compression of a medial nerve. So, as I said, the focal affect a single nerve or nerve group, and usually these are caused by an acute ischemic event or by nerve cramping. Recovery time can vary, but they can recover from this type. Other complications, visceral neuropathies of the autonomic nervous system. So sweating, dysfunction or anhydrosis, which is the absence of sweating. And this may occur on the hand and feet, or hands and feet. And increased sweating may occur on the face or the trunk. Abnormal papillary and pupillary function. Pupillary dysfunction is usually pupil constriction that dilates very slowly in the dark. Cardiovascular dysfunction. The heart rate stays the same even with exercise and may experience postural hypotension and failure to increase cardiac output or vascular tone with exercise. The GI system or gastrointestinal dysfunction. The stomach gastroparesis, which is delay in gastric emptying and is caused by hypoglycemia, that results in decreased appetite, or causes, the delay in gastric emptying causes hypoglycemia. And this results in decreased appetite, heartburn, nausea, vomiting, and altered blood glucose control. And also constipation is also common. Genitourinary dysfunctions. They can have the inability to empty their bladder completely because of the loss of sensation of bladder fullness. And this also increases their risk for urinary tract infections. Sexual problems, ejaculatory dysfunction and impotence in men. Females, changes in arousal patterns, lubrication, and orgasm. Alterations in mood, of course, strains of living with a complex self-care disorder, and they're at risk for depression because of this. And they're increased, they have an increased susceptibility to infection. Vascular and neurologic impairments cause this, and nephrosclerosis and urinary retention, as we just talked about. So bacterial and fungal infections of the skin are common, nails, and mucous membranes. And also TB is more prevalent in people with diabetes than in the general public. They found that hospitalized clients with a blood sugar that is greater than 220 milligrams per deciliter have a higher rate of infection. Diabetics have a high risk, or are at high risk for amputations if they have diabetes for more than 10 years. The risk factors for amputation are diabetic more than 10 years. Males tend to have more amputations. Of course, if blood glucose is not well controlled, and if there is cardiovascular, retinal, or renal complications involved. Vessels that are more likely affected are those below the knee. And complications involving the feet, of course, diabetics, if they have neuropathy, this produces multiple problems because they don't feel, right? They don't have the nerves to feel that they've stubbed their toe or stepped on a nail or any of those kinds of things. The most common traumas that occur are cracks or fissures from dry skin because of force regulation, blisters and pressure. I mean, they can't tell if their shoes don't fit right or feel uncomfortable. Ingrown toenails. Sometimes they have ingrown toenails that are treated by a podiatrist, and then they end up getting an infection from that. So it's like a no-win situation there. They usually begin as a superficial ulcer and, of course, extend deeper. So the key is to keep closely controlled blood glucose. This reduces the risk of complications by 60%. The focus of treatment, of course, is to maintain blood glucose at nearly normal levels through using the medications that they should, using their insulin and their anti-diabetic PO meds, dietary management, and exercise. Some of the diagnostic tests that indicate diabetes are if the patient's having symptoms of diabetes and their plasma glucose is greater than 200 milligrams per deciliter. Their fasting plasma glucose is greater than 126. Their 2-hour plasma glucose is greater than 200, and their oral glucose tolerance their 2-hour plasma glucose is greater than 200 with the oral glucose tolerance test. So the following levels for a fasting plasma glucose: the normal fasting glucose should be 100 or less. And impaired fasting glucose is greater than 100. From 100 to 100. Okay. Oh, I'm sorry. It's impaired. Excuse me. Normal is 100. Impaired is greater than 100. Less than 126. And then we get to the next slide. Sorry. Each of the tests that are used to confirm the diagnosis of diabetes mellitus must be repeated with the same or similar results to say that that person is diabetic. Okay, diagnosis of diabetes is if the fasting blood sugar is greater than 126. And the following levels are used for the oral glucose tolerance test. So the normal glucose tolerance 2-hour plasma glucose should be less than 140. Impaired would be greater than or equal to 140 and less than 200. And diagnosis of diabetes is greater than 200. Pre-diabetes is considered 100 to 126. And that these folks are at increased risk of developing diabetes. So pre-diabetes, just because someone's pre-diabetic does not mean that it's inevitable that they get diabetes. If they implement weight loss and exercise, they can prevent or delay the onset of diabetes. A real popular test that we're doing these days is the glycosylated hemoglobin, or A1C. I'm sure some of you have seen that on your patients in the hospital. Or also called hemoglobin A1C, HbA1c. And this shows the average blood glucose over 2 to 3 months. So it can show, well, first of all, the normal would be 4 to 6%. levels greater than 6.5 are diagnostic of diabetes mellitus. And it can be done to diagnose, and it can also be done to monitor compliance with their blood sugar control. So they will get these on diabetics to see how well their blood sugar's been controlled over the last 2 to 3 months. We used to do a lot of urine glucose testing and ketones, but they're not as accurate, so they're not used as often anymore. Urine tests for protein. We're also going to check serum cholesterol and triglyceride levels and electrolyte in these patients. So, A1C levels kind of give you an idea of what their glucose blood sugar is. If it's 6, it's 126. If it's 7, it's about 154. If it's 8, it's 183, and so on and so forth. So that kind of gives you an idea of what their average blood sugar has been. Okay, so the triangle of diabetes management, exercise, diet, medication, and of course, glucose monitoring. Those are the keys. So how often should blood glucose be monitored? It depends. Urine testing, like I said, we don't like to do urine testing because it cannot measure hypoglycemia, so we don't use that for that reason. Type 1 diabetics should monitor their blood sugar at least 3 or more times a day. Type 2 need to monitor their blood sugar until their blood sugar is, they've met their goals for where their physician wants their blood sugar to be. But any time that there is a change in routine, you want to monitor that we want them to monitor their blood sugar more often. So, self-monitoring of blood glucose allows diabetics to monitor and achieve control. Decreases the danger of hypoglycemia. And we talked about the frequency. And there's all kinds of different machines, monitoring machines. And there is a continuous glucose monitor, which is a new pump, which sounds really neat. But the problem with that is that, well, how it works is it monitors glucose levels in the interstitial, or the space or gap between the tissue, fluid between the tissue. It's very expensive and is meant to supplement, not replace, finger sticks. So the patient still has to do finger stick blood sugars. So I was disappointed when I read about that. It sounds like a great thing, though. Like I said, it's just to be used as a supplement, and insulin should never be given until the blood sugar is confirmed with a finger stick blood sugar reading. So we're still working on getting those better. That would be great. So the equipment needed to test your blood sugar is a lancet, chemically impregnated test strips, and a blood glucose monitor. Clients with higher hematocrit come up with a falsely low blood glucose, and lower hematocrit end up having a higher glucose level. There are some medications that can cause inaccurate results with the monitors. Some of those are uric acid and an antioxidant called GSH, or glutathione, GLUTATHIONE. O-N-E. And ascorbic acid, is also known to interfere with the results. So we just want to make sure our patients know that the test strips need to be compatible with the meter. So drugs that can affect the blood sugar, some of the drugs that lower blood sugar are Tylenol, allopurinol, beta blockers, anabolic steroids, potassium salts, aspirin in large doses, and tricyclic antidepressants. And as we discussed before, things that increase blood sugar, alcohol, Diamox, caffeine in large doses, birth control pills, calcium channel blockers, clonidine, morphine, epinephrine, Lasix, the famous corticosteroids, marijuana, phenobarbital, and Dilantin. We need to keep those in mind. Patients are having problems with high blood sugar. So insulin is used by patients definitely with type 1 diabetes. They need to have a lifelong exogenous source of insulin, which is not a cure, but rather a means of controlling hyperglycemia. Also, patients who are unable to control their glucose levels with oral antidiabetics and or diet may have to also have insulin. With physical stress, infection, or surgery, or taking oral corticosteroids, a patient might end up having to have some insulin when they're in the hospital. Definitely with DKA and HHS, they'll need insulin. And our patients who are on high-calorie tube feedings, and as I said earlier, TPN, their blood sugars will go up, and they may have to have insulin while they're on those. Insulin is derived from animal or synthesized in the lab. Insulin Lispro or Humalog is a rapid-acting, ultra-short-acting. Regular insulin is short-acting, and both these are clear. Regular insulin is the only insulin that can be given IV, and it is used to treat DKA. And I will give you a list of the medications that you'll need to know for the test. And with insulin, you need to know the onset, duration, peak and duration. But I'll just pick out a few for you. There's songs, and there's always more coming out. So I'll let you know the ones that you need to focus on. NPH insulin is manufactured using DNA technology to synthesize pure human insulin. Insulin analogs are synthetic human insulins in which the structure of the insulin molecule is altered to change the rate of absorption and duration of action. Clairgen or Lantus is not recommended for pregnancy. And you do not mix Lantus with any other insulins. The pH is incompatible. So the NPHs are cloudy insulin. The Lantus is our 24-hour acting rDNA human insulin analog, and it has a constant effect. and no peak time. Did Miss Walker talk about mixing insulin when you guys were doing medications? Clear to cloudy. Everybody knows how to do that. Put your air in your cloudy and then come back and put your air in your cloudy. And then draw up your clear first. So you draw up clear to cloudy. Make sure they are compatible. So our clear is our fast acting, and our cloudy is our longer acting. So as we were just saying, a short acting insulin, regular with a long acting insulin, and pH. Insulin is dispensed in either 100 units per milliliter or U100 or 500 units per milliliter or U500. We don't use, it always makes me nervous to use U500. They're used in rare cases where their insulin resistance is very high and that when the patient needs large doses of insulin. But thank goodness we don't have to look at that very often. All insulins are given parenterally, subcutaneous. Regular or rapid-acting insulins are used in continuous insulin infusion devices. Just a few little things about it. You only want to keep the insulin for like 4 weeks. After 28 days, after 30 days, the potency of the insulin goes down. If the patient has their insulin at home, they can keep it out of the refrigerator, but any storage of any other insulin should be kept in the fridge, and you'll see that at the hospital. Some nursing homes keep it out, but typically it's better to have the insulin warmed a little bit because it can cause tissue damage. But of course they want it to be stored in a cool place, not exposed to the sunlight or extreme temperatures. You want to make sure that they know to discard any vials that have discoloration or clumping or granules or solid deposits on the side. And of course, if breakfast is delayed, also delay the administration of rapid-acting insulin. With my students, I always say, we won't give insulin until we see the trays on the floor. How fast does rapid-acting insulin kick in?
30 minutes.
Rapid-acting.
15 minutes.
15 minutes. Yeah. So we want to make sure that we see those trays because their blood sugar could bottom out before those trays get there. And as you know, they're inconsistently brought up on the floor. So that's kind of the rule I have for that. Symptoms of hypoglycemia occur, we want to make sure that we check a blood sugar and administer an oral source of fast-acting carbohydrate, as we talked about, juice, milk. Picture of continuous insulin infusion device, and the dosage and instructions are entered into the pump's small computer, and the appropriate amount of insulin is then injected into the body in a calculated, controlled manner. And you can see how that's warmed. So they typically receive receive a basal dose, and then when they eat a meal, then they dose themselves. And we'll talk a little bit about carbohydrate counting and that kind of thing. Type 2 diabetes that cannot be managed with oral medication when hospitalized. A lot of times they're on insulin. ICU patients. There is less morbidity with intensive insulin therapy. And this insulin decreases the risk of post-operative infections. IV insulin infusions maintain normal blood glucose but require frequent monitoring. The continuous insulin pumps allow for more normal regulation of blood glucose, lifestyle flexibility, and the important thing is that the needle site must be kept clean, and the patient needs to be instructed on washing their hands and changing the site and those kinds of things. They have special injection products. Vials are at room temperature. Like I said, up to 4 weeks is okay. Regular insulin requires no mixing. Other types require gentle rolling. So if you're just giving regular insulin, you don't have to roll it, but if it's NPH, then you need to just gently roll it. You don't want to shake it because it can get bubbles in it and foam in it, and then it might alter the dose that you're pulling out. So just gently roll it. To rotate sites. You do not massage the site because that can alter the absorption of the insulin. However, it's good to put a little pressure on that site. And we need to teach them techniques for minimizing painful injections. What can happen is okay, just to back up, the rate of absorption, the rate of absorption and peak of action can differ according to the site used for injection, so patients need to know that. The most rapid absorption is in the abdomen, and then the deltoid, then the thigh, and then the hip. And I would say that's probably why we most of the time give it in the abdomen at the hospital. Used to be Rowan had a policy that we only gave it in the abdomen. They've kind of gotten away from that a little bit, and we have been giving them in the arm also. So also we want to make sure our patients know not to inject insulin into an area about to be exercised or heated, because what will happen with that? Yeah, it'll increase the absorption of the insulin and could cause them to have some hyperglycemia. The lipodystrophy is the hypertrophy of subcutaneous tissue, and the lipoatrophy is the atrophy of subcutaneous tissue, which can happen if they tend to inject in the same spot all the time. So we do need them to rotate the sites. And next I have a picture of the different sites we can give insulin in. It's good to instruct. It's hard for patients to do the arm at home. I did see a patient, one of the nurses I worked with go up to just to get a different site. She kind of roll her arm and give it. So I thought that was a pretty good technique to be able to give yourself an injection in the arm. But you know, back here is really hard. But there are several sites. So I'd say the abdomen probably gets the majority of the injections. So hypoglycemic agents, or by by-mouth antidiabetics are used to treat type 2 diabetes mellitus. Different ones work differently, but they can either stimulate or increase insulin sensitivity, so the cells will accept the insulin that they're producing, prevent the breakdown of glycogen to glucose, and make cells less resistant to insulin. Most of those are oral preparations. There is an injectable called Vita, and it has several modes of action, but it is an injection, and it signals the pancreas to make insulin when nutrients are ingested and stop insulin release as the blood sugar normalizes. It also stops the liver conversion of glycogen to glucose and decreases the absorption of sugar from the intestines. Aspirin therapy, a lot of times, is implemented once a day dose of 81 to 325 milligrams. It is recommended to reduce atherosclerosis. People with diabetes, as I said earlier, are up to 4 times more likely to die from cardiovascular disease. So this is a good prophylactic thing to give our patients to at least thin their blood. So the management of diabetes, again, balanced nutrition, nutrients, expenditure of energy, exercising, and dose and timing of meds are very important. The ADA guidelines on nutritional therapy focus on achieving and maintaining as near normal, want the patient to achieve and maintain a near normal blood glucose level, achieve optimal serum lipid levels, achieve the blood pressure in normal or near normal range, modify nutrient intake and lifestyle, address nutrition considering personal and cultural preferences and willingness to change, and maintain pleasure of eating by only limiting food choices indicated by scientific evidence. If our patient doesn't like certain things, we can't expect them to eat certain things, so we need to work with their personal preferences, definitely. And also meet nutritional needs of the unique times of when diabetics are pregnant or lactating and older adults. Provide self-management training for patients regarding safety, regarding medications, preventing and treating hypoglycemia, and management during acute illnesses. Did you want to say something?
I want to, at the end, whenever you're finished, when you get to it, I know they're all stressed out about
They
clothes,
are.
so I'm trying to.
And Jeff said his wife said it's snowing in Salisbury.
So, I don't want you finish up.
That's okay. Go ahead. Go ahead. Yeah.
Sorry. Okay, guys, I'm trying to figure out